Hey guys, and thanks for joining me for the pandemic edition of immune-mediated diseases of the anterior segment. This is Brandon Ayres from the Cornea Service at Wills Eye Hospital, and once again, thank you much for joining me on this journey here. So our general outline is going to look like this. We're going to talk about most of the common inflammatory conditions of the anterior segment, starting with things like episcleritis, moving on to scleritis and peripheral ulcerative keratitis, Thygoson's SPK, OCP, Stevens-Johnson. It'll get more complicated as we go, and we're going to start with episcleritis. We see episcleritis very commonly in the office. By definition, episcleritis is inflammation of the episcleral tissue. It tends to be seen in adults, and it's often bilateral, although not always at the same time in both eyes. The presenting complaint is often redness and mild ocular discomfort. People may think that the eye feels a little bit sore, it's a little bit red, but this is no terrible pain. The exam often shows those bright red episcleral vessels. If the eye is numbed with proparacaine, you take a cotton tip applicator. If you kind of move the conjunctiva, the redness will often move with the conjunctiva and episclera, and it's really minimal pain to palpation. So if you happen to lightly touch the eye, the patients don't jump off the bed or jump out of the chair. This is a good example or clinical photo of what episcleritis is going to look like. Remember, if you put some phenylephrine on this, the large majority of these episcleral vessels are going to blanch and the eyes can become white again. So if you come in the room after somebody has already dilated a patient, you can completely miss the presentation. So you want to see a patient like this before any phenylephrine or dilating drops are placed on the eye. Now, very often patients are convinced that they have some kind of horrible medical condition that's causing this episodic redness, and that's actually very unusual in episcleritis. So I have done some workups, but rarely, in fact, I don't think I've ever seen somebody with an associated immune condition. Now, I have seen people who know they have autoimmune conditions come in with episcleritis. So what's true for one may not be true for the other. Now, blepharitis, ocular rosacea, chronic ocular surface disease with meibomitis, those are much more common. Actually, I've seen Demodex several times also implicated in episcleritis episodes. That's more what you're looking for, more so than the autoimmune diseases. Pingueculums, the elevated tissue off the surface of the eye, can lead to a little pingueculitis or episcleritis. The inflammation tends to be self-limited and will often go away on its own, or just take some mild anti-inflammatory in the form of either a non-steroidal or a mild topical corticosteroid. And there can be nodular episcleritis, especially that'd be something like a pingueculitis, or it can be diffuse, with more diffuse inflammation of the vessels. Again, the inflammation tends to be very superficial. It's often mobile, especially if it's a nodule, so you can move it with the cotton tip applicator. Minimal pain with palpation, and it's going to blanch with phenylephrine. Treatment is usually treat the underlying source if you know what it is. So most of the time these patients end up on an ocular surface regimen with maybe a mild steroid for a couple of weeks, then using some kind of a prescription anti-inflammatory for dry eyes such as cyclosporin or lifitegrast. Topical and oral nonsteroidals can be very effective, although I don't like to use them myself for a very long time, but they certainly are helpful. And topical steroids rarely necessary for long-term control, but they do work to help get patients more comfortable relatively quickly. So just a short burst of topical steroid, at least that's how I like to treat these patients. Really not necessary to do a workup for underlying disease, but I will do it in some cases, even if it's just to help a patient feel a little bit better and understand that they don't have any kind of terrible medical problem underlying their red eye. Now, scleritis can be a different game. This is an inflammatory condition affecting the sclera that often induces destruction of the sclera. This is very commonly seen in people with autoimmune disease. And the presentation is much more violaceous, it's much more red, and it's got this horrible pain, and patients will jump right out of the chair if you start pushing on their eye when they have active scleritis. Interestingly, the scleritis can be a little bit difficult to diagnose or see when you're using the slit lamp, and sometimes it's helpful to actually sit back and use the room light to look at the sclera. That for whatever reason, makes it much more obvious how red the eye is. It's amazing how sometimes the slit lamp can hide the amount of violaceous hue that patients have. Now, scleritis is often split into different classifications, and so for the splitters, we have our scleritis, and that can be divided into anterior and posterior scleritis. And in the anterior world, you've got diffuse, nodular, and necrotizing. So those are 3 different forms. We're not going to talk much about posterior scleritis today, as I am a cornea specialist and I don't do posterior work. So the diffuse anterior scleritis is the most common. Okay, we're going to see diffuse involvement of the anterior sclera, and then about half of the cases is the entire sclera that's involved. I guess it's just a little under half the cases, at about 40%. Nodular scleritis is a little less prevalent. It's about 14% of what we see. This is going to have an elevated non-mobile nodule of sclera that's highly involved in. When you touch on that nodule, your patients are going to punch you right in the face. So don't touch it too hard, or if you do, make sure you duck and weave. Necrotizing scleritis is the most rare and the most severe form of scleritis. And in some cases, this can progress and involve the entire sclera. Basically, you get a melting eye. About 60% of patients diagnosed with necrotizing scleritis will end up with an ocular or systemic complaint, and about 40% will lose vision. So this really is destructive. In fact, I always forget the number, but there's a significant chance that your patient will die of vasculitis once they're diagnosed with necrotizing scleritis. So these tend to be sick patients with really severe ocular disease. So we want to get these worked up and treated as quickly as possible. There's minimal signs of inflammation, but very rapid loss of tissue. Sometimes the redness and pain are absent, but you'll be able to see that dark uveal tissue as that sclera becomes thinner. And again, this is almost always in people with advanced collagen vascular disease, so usually you already know your underlying diagnosis, so you don't have to work these patients up. However, if you see somebody with necrotizing scleritis and they don't have a collagen vascular diagnosis, it's time to go on a hunt and figure out what it is. Here's just a couple of images of patients who've had really severe scleritis. You can see that the after effects, the blue sclera, we'll often see staphylomas. It's not uncommon. If you look closely at this picture, you can see the keratitic precipitates. So remember, scleritis and uveitis tend to run as a group, and you can see inflammation inside the eye as well as on the eye. Here, if you look closely in the upper portion of the picture, you can see a little translumination defect. This is a large scleral staphyloma. This eventually had to go on to get repaired, but at this stage, we were able to just watch this staphyloma. It wasn't causing any problems. Peripheral thinning, a peripheral ulcerative keratitis, often coexistent with scleritis, so watch for these advancing waves of corneal inflammation. And notice on the bottom of this picture, you can see an area where the patient had an episode of peripheral ulcerative keratitis in the past that's now healed up. This is a patient with active acanthamoeba and acanthamoebic scleritis, and you can see both a very inflamed and elevated portion of the sclera right next to an area that's very, very thin. And here's a patient of mine with chronic uveitis and scleritis who had a keratoprosthesis. And one day she came in while we were in the operating room, and she called and said, "Hey, I think my contact lens came out." So we said, "Well, come on into the clinic." And then she handed us her contact lens, and what she handed us was this. This is actually the keratoprosthesis that fell right out of her eye. Luckily, there was a dense enough retroprosthetic membrane that although the prosthesis fell out, the eye stayed intact, and we didn't have to do any kind of emergency surgery, although it didn't take us too long to get her back into the operating room to repair that cornea. Now, this is an example of a staphyloma repair. You can see this very large staphyloma. And this is a patient with known collagen vascular disease. She's relatively well maintained by her rheumatologist, but we had this very slowly growing sclerostaphyloma. I don't think that it was necessarily growing in the horizontal diameter. It was just slowly stretching, and I think once you reach a critically thin measurement of the sclera, just the intraocular pressure is going to cause progressive ectasia, if you will, of that scleral mass. So our plan here was to to make a patch graft that is going to completely cover and compress that staphyloma. Not an easy task, and a lot of these surgeries you're kind of making them up as you go. So here we're just dissecting a little edge of the corneal limbus so we have a edge to suture into. We're also going to do a vitrectomy. It's hard to tell in this video, but that staphyloma is really elevated, and there's just no way that we're going to compress all that fluid into the eye and flatten that staphyloma. So by doing a limited vitrectomy, we're going to remove some vitreous. Now we can much more easily compress and flatten that staphyloma so that we can get our patch graft to stay in place. Now, admittedly, an error that I made in this surgery is I thought that I'd be able to cover this staphyloma with a patch graft made from the top or the cap of a desec button. But in the operating room, that staphyloma was way too big, and the tissue that we had cut was way too small. So here we are just kind of making it up as we go, where we're taking the remainder of the scleral rim and what's left of the endothelial graft, we're going to use that as our patch graft. So we're going to suture that edge of the sclera right into that little edge that we created just a few minutes ago to give us a nice transition from the sclera to the cornea. Once that's tacked in place, we can tie down our scleral patch graft. I'll fast forward a little bit in the interest of time, but you can see the need to be somewhat creative and flexible surgically, because you really are not sure what you're going to do in these cases until you get there. So you can see here we've got that patch graft just draped over the staphyloma, and then with some very tight sutures we can compress the staphyloma and get it to be, we'll get that to lie relatively flat, and in the end it looks pretty good with the remainder of the contour of the eye. And so here are the clinical photos after this surgery. Now what you don't get a sense of is how elevated that staphyloma used to be. It actually looks pretty good. You can still see the blue sclera underneath because we used a corneal patch graft, so the tissue was relatively translucent. But over time the conjunctiva sort of grew over that area of the cornea, and cosmetically it was very acceptable, and certainly a lot bigger than this the patient's prior picture, which basically had a second eye growing out of the first. So the workup for scleritis is basically an autoimmune and inflammatory workup. The basic science book tends to recommend a CBC, ESR, CRPs, rheumatoid factor, double-stranded DNAs, your ANCAs and ANAs, FTA, RPR, chest x-rays, ACE and lysozyme. I will sometimes add a little bit more, and every time I send a patient to a rheumatologist and they start adding labs that I don't recognize, I'll try and give them a call and see what why they added what, and then I'll add that to my own workup. So now we're certainly also doing either a PPD or a quantiferon gold, testing for TB. I often add the complement levels and a PR3, proteinase 3, which can be helpful at diagnosing rheumatoid arthritis. Either way, I think as long as you do a fairly comprehensive inflammatory workup, you've done your job at trying to make sure your patients are safe. So topical steroids are rarely used in the treatment of scleritis, but I wouldn't say they're never used. The addition of difluprednate has changed to a small degree the treatment regimen, and I do think there are some times where topical steroids can be helpful. But generally speaking, the plan is systemic steroid or systemic anti-inflammatory. And it certainly will depend on the severity of the disease as to what you reach for first. But the treatment goal is get rid of the ocular inflammation and try your best to minimize the need for long-term oral steroids. So what if this treatment is relatively mild? Well, here we're going to, of course, do the workup. I don't care if the scleritis is mild, moderate, severe. I think the workup is necessary unless the patient has a known diagnosis. Topical steroids here may reduce the discomfort patients feel, and it may be enough to treat these mild cases, especially if you're using difluprednate. Oral nonsteroidals are definitely beneficial. They will help right away knock out some of the pain. It can be used longer term as an anti-inflammatory. But many of these patients are going to need an oral steroid with a relatively slow taper. And when you're going to use that oral steroid, I often like to also institute some kind of safer anti-inflammatory that will eventually transition to. So systemic immunosuppression may be important, or is important, I think, in many of these patients to help prevent recurrences. Now, if that scleritis gets a little bit more severe, again, work it up. Here I don't really think there's much role for topical steroids. We're going to go right to higher dose oral or IV steroids. Sometimes cyclophosphamide can be of benefit in these patients. And these will often need chronic immunosuppression. And I don't really pretend to know what I'm going to start these patients on. In my office, I will often use a medication called Acthar, which is basically corticotropin, but methotrexate, Cellcept, Remicade, Humira, many of these can be used to be our steroid-sparing agent. I am usually doing this with the help of a immunologist or rheumatologist. Sub-T non-steroids can actually be helpful. Subconjunctival are not helpful, but in somebody who we are tapering an oral steroid, they get a little flare of their scleritis, I will do on some occasions a sub-T non-steroid injection to try and control the ocular symptoms without having to go up on the PO steroids. And like I mentioned before, these are often being co-managed with a rheumatologist or immunologist. And here are just a couple of images of patients of mine with some of the manifestations of more severe scleritis, including the scleral thinning and staphyloma formation. And you can see a little residual scleritis in that image on the left, but also you can see that creeping line of inflammation in the cornea, which brings up our next topic, which is peripheral ulcerative keratitis, also known as PUK. All right, once again, we've got our lumpers and splitters, and peripheral ulcerative keratitis can be divided into two categories. One is with inflammation and one is without inflammation. And let's first talk about peripheral ulcerative keratitis with inflammation. So again, typically associated with collagen vascular disease like rheumatoid arthritis, relapsing polychondritis, you pretty much name it. We've also seen it with viral infections. You can see PUK in people with shingles, HCV, HIV, a systemic manifestation of TB. It's not real common, but you can see it. So here, a medical underlying diagnosis is very, very common. Etiology here is immune-mediated vaso-occlusive disease, and these melts tend to be due to T lymphocyte infiltration, so we'll often try and target the inflammation using a T cell modifier. At least we try and be scientific like that about it, although sometimes you see these cases and you just kind of pee your pants and do the best you can. So patients will often present similar to scleritis, very red, very painful eye. Involvement can be bilateral. It's usually sectoral. So it's rare that you see the entire cornea involved, but it is not impossible. And the epithelium at the limbus is going to be gone. There's going to be an epithelial defect. It's either thin or absent in most of these cases. And that keratolysis can be very, very rapid, and in many cases can lead to perforation. So here's a patient of mine, and you can see that area that looks like a pterygium is actually conjunctivalization of the cornea right up to the area of a gutter where this patient had a previous PUK. And in this clinical photo, you can see this very red eye, very angry eye, and that white line or white arc of infiltrate. If you see that infiltrate at the limbus, you know that a PUK is either starting or already moving. Even if you don't see the epithelial defect, that area is going to break down and form your gutter and may eventually look like this. This is a young patient of mine who had a rapidly progressive peripheral ulcerative keratitis, and we never figured out why he had it, and he ended up going on to need multiple surgeries to correct this. And I actually just saw this patient the other day. He's now all the way through college, which makes me feel pretty old, but doing well, and he's maintained good vision, has not had any recurrences. Here's an area that has a large conjunctival and corneal epithelial defect associated with the necrosis of the sclera and cornea, and here you can see that white area of the cornea. This is a very alarming exam. We want to get this patient on treatment right away. So the treatment here, the idea is to maximize or improve the ocular surface, lots of lubrication, plugs, tears, stop that keratolysis so we can promote healing, and then again use some immunosuppression. Many of these patients will need long-term immunosuppression. So how do you do that? Well, many of these patients have an associated dry eye, and it's maybe a couple times a year that a patient comes into the ER, and I call this the little old lady melt, where they've got severe ocular surface disease. They end up with a paracentral, probably a dull or dry spot that very quickly cores into the cornea and perforates. Okay, the image like you see there on your left is not a peripheral ulcerative keratitis. That's not an inflammatory melt. That's more of a dry eye melt due to very poor tear film and desiccation of the cornea. Okay, this we're going to treat with artificial tears, plugs, lots of ointment and glue, maybe a bandaged contact lens or a self-retaining amniotic membrane to try and get that to heal. If it doesn't heal, then we'll move on to a surgical fix, but this is not necessarily inflammatory. Okay, to decrease the inflammatory melts, you got to stop that keratolysis and really promote the epithelial healing. So how do you do that? What are our MMP9 inhibitors? Well, we got things like doxycycline, we got mucimist or acetylcysteine 10%, medroxyprogesterone, sodium citrate. Topical steroids probably do stop keratolysis, but there is some concern about using them long term as they may reduce epithelialization. Although if somebody is in bad shape, I don't think there's any harm in putting a topical steroid on. Conjunctival resection to try and stop the mediators from getting to the limbus has been performed. I've done that a couple times myself. An amniotic membrane transplantation, whether it's a transplant or a self-retaining AMT or an AMT underneath a therapeutic bandaged contact lens, all those may be reasonable for trying to decrease the inflammation and keratolysis in a patient with peripheral ulcerative keratitis. Sometimes they move on to need high-dose oral or IV steroids, very similar to a severe scleritis. Cyclophosphamide or other immunosuppressions may be necessary. I like using cyclophosphamide in some cases because it works relatively quickly, faster than some others, but it certainly has a side effect profile that some patients don't appreciate. Gluing can be helpful, but it only buys time. I'm not a huge fan of gluing a cornea and then watching that glue for years and years. It usually is a way for me to try to quiet the eye down, to get the eye in a better condition to accept some kind of crescentic or tectonic graft down the road. And here we got a clinical image of a nice crescentic graft in a patient with a peripheral ulcerative keratitis. Now, PUK without inflammation is its own deal. When you do your workup and it comes back negative and we don't see an inflammatory condition, we call it a Moorens ulcer. There probably is some kind of autoimmune etiology. We just don't know what it is. And this can be precipitated by things like surgery, trauma. There's reports of helminthic infection setting off a Moorens ulcer. This tends to be primarily corneal involvement. There's a little less sclera in these patients, but they can still perforate and they can be just as challenging, if not more challenging, than your more traditional PUK. We usually divide this up into two different types. Type 1 tends to be more unilateral. It's an older patient population, more slowly progressive, and is seen more in men than women. Type 2 is our bilateral, more common in African American patients. This one absolutely loves to perforate and it's rapidly progressive, very difficult to treat, and I'll show you an example of this in just a few minutes. Treatment is as you expect. We're going to give our patients anti-keratolytics, that's our doxycycline and our citrates and our medroxyprogesterone, bandaged contact lenses, glue. Some patients will need conjunctival resections and patch grafts. And even though we don't often, or in Moorens ulcer, we don't ever have an inflammatory diagnosis, we often will immunosuppress them anyway. Another picture of a patch graft over that patient who had those two small perforations. You can see that's that little tiny corneal patch graft to cover those perforations up. Now here's a much more severe form of Moorens. This poor patient, workup was negative. Both eyes are involved. This is the more severe of the two. And in this video, we have already taken this patient to the OR and done a conjunctival resection and placed AMT in the area of the gutter, which in this case is 360 degrees around. We actually admitted this patient for urgent treatment with immunosuppressives and steroids, working with rheumatology. And this eye just kept hanging on. We swore that he was going to perforate. but he just kind of kept hanging in there. So eventually we said, well, we got to do something to try and keep this eye. So here we're doing a 360-degree limbal patch graft. So that gutter all around the edge left that central island of relatively untouched normal cornea. So we measured that central island. We took a large corneal transplant. We tree-fined out the center, the same size or similar size as the healthy portion of that central cornea. And then we just basically transplanted the entire limbus. We also did, and you could see it there, another conjunctival resection, and basically that just gave us an area to suture this keratolimbal graft to. So here we're going to suture the what we're going to call the graft host junction, that's the patient's cornea to the limbal cornea. Then after getting that secure, we will then go back and suture the sclera portion to the patient's sclera beyond the area of the thinning. This is a very long surgery, very challenging surgery. And now we're also pulling the conjunctiva back up to this newly created limbus. The idea there was to try and make a relatively smooth transition to prevent dell formation and stop this keratolimbal graft from simply desiccating and falling off. And by some miracle, this actually worked. This graft held. The patient's eye healed very nicely, and he actually retains a remarkably normal looking eye and usable vision in this eye. This is definitely one of those patients who I expected to perforate and lose his vision, and by trying real hard and being persistent, we were able to save his vision. Still a great guy and very grateful for the work that we put into him. So on to some of the more unusual things. Thygeson's SPK. This is an alien-like condition that nobody is really sure where it comes from. It's an epitheliopathy of unknown etiology. Causes a lot of foreign body sensation, photophobia, reduced vision, especially if it's in the visual axis. Very, very quickly responds to topical steroid therapy. And you don't need strong steroids. Even very weak steroids will work. We've also tried non-steroid anti-inflammatories like cyclosporin and levetiracetam. They probably do work to a degree, but in these cases, nothing works like a low-dose topical steroid. So you can see the SPK in these patients looks a little bit different. You look at high mag, and it kind of has this granular stellate look to it. It's not just a dry spot. There's something there. I've seen these lesions look very, very large in some patients to the point where you question your diagnosis. But once again, with a little topical steroid, they completely vanish. And these patients tend to get very good at monitoring their symptoms and doing self-treatments with increasing or decreasing the steroids or the cyclosporin or whatever they're using to help treat things. Topical bandage contact lenses, ointments can also be very helpful. Some people have said that cyclosporin is a slam dunk in these patients. That's not been my experience, but I do think that judicious use of topical cyclosporin, 3 and 4 times a day, even in the prescription available dose at 0.05%, is enough to help lessen the steroid burden in these patients. Now the real challenging patients. Ocular cicatricial pemphigoid, now called mucous membrane pemphigoid. This is chronic ocular surface irritation due to inflammatory mediators. This is a type 2 hypersensitivity reaction. That question was on my board exam, causing a progressive cicatrizing conjunctivitis due to antibodies to the basement membrane zone. Okay, it's associated with HLA-DR4, more commonly seen in women than men and in an older patient population. Other mucous membranes can also be affected, but we are usually dealing with the conjunctiva, of course, in the eye care world. Patients will present with these recurring bouts of conjunctivitis, red inflamed conjunctiva that then ends up forming cicatrization. Dry eye is often coexistent with OCP, which makes things even more challenging. And make sure when you talk to your patients, you also ask them about lesions elsewhere. The stages of OCP include a stage 1, where you'll just see some subepithelial scarring and fibrosis. Stage 2, you see the fibrosis as well as loss of goblet cells. Now, of course, you can't necessarily see the loss of goblet cells, but it can be detected if you're using something like impression cytology. But especially, you will notice the shortening of the fornices. So no symblepharon, but the fornix is starting to zip up. And with OCP, you tend to get shortening of the fornix starting in the fornix, and then moving forward, other cicatrizing conjunctivitis may give you symblepharon formation but allow that fornix to stay deep. So that's one of the ways that you can try and discern OCP from other forms of symblepharon formation or other etiologies for symblepharon formation, like bad conjunctivitis or a chemical injury. Stage 3, you're going to have symblepharon, and stage 4 is when you have adhesions between the eyelid and the globe, so that the lid is actually frozen. So here's a good example of a patient of mine with OCP. Have the patient look up and put a little traction down in the lid, and you can see these stage 3 symblepharon forming, and he's got some foreshortening of the fornix. You get on to stage 4, you've got complete conjunctivalization of the eye with frozen lids. Our only option in these cases, realistically, is going to be to do something like a through-the-lid keratoprosthesis, which we've done a limited number of. This is the first patient I did a through-the-lid keratoprosthesis, who actually maintained very good vision, driving vision, in this eye for as long as he lived. And this fellow would come in, and I'd have to do YAG lasers to clean off the posterior aspect of the capro every couple of weeks. And he would come in, I'd do a laser, and he'd drive his motorcycle home. It was the most terrifying thing I've ever seen in my life, but he appreciated the help that we gave him. Diagnosis and management. Well, definitive diagnosis is with a biopsy in the active area. You're looking for IgM, IgA, IgG, and C3. These have all been seen to be laid down in the area of the basement membrane of the conjunctiva. And many of these patients will end up, in fact, I'd say 9 out of 10 of these patients end up on systemic immunosuppression. Dapsone has come back, but you got to watch out for patients with G6PD deficiency. Cytoxan, methotrexate, Cellcept, azathioprine, all of them can be used. And you'll see these medications used in the OCP clinic. In many cases, they'll also need surgical intervention to help with eyelid malposition, misdirected lashes, takedown of the symblepharon if they're causing problems. But if we can avoid surgery, we often do, because the surgical outcomes are not always great. Other etiologies of cicatrizing conjunctivitis is going to be things like infections, EKC, trachoma, trauma, other autoimmune conditions, Stevens-Johnson syndrome, scleroderma, graft-versus-host disease. Even the atopic patients will often get this. I've seen terrible symblepharon in rosaceal blepharitis. And don't forget about those terrible drops and drop toxicity, things like pilocarpine, timolol, idoxuridine. We don't really see that anymore, neither do we see ecothiopate. But just don't forget that anything that's toxic and goes into the eye can also cause symblepharon. Stevens-Johnson syndrome. Okay, this is a disease characterized by a subepithelial bullae and scarring caused by immune complex deposition in the dermis and conjunctival stroma. In particular, Stevens-Johnson will have minimal skin involvement. Once you get to more skin involvement, 30% or more, it's now called toxic epidermal necrolysis. So really the same process, just more skin involvement. Most commonly elicited by medications. I've seen patients from Zyrtec, from aspirin. Sulfonamides are more common, anticonvulsants quite common. But any medication can do this. And you can even have it be elicited by an infectious organism. We have one patient that I can recall with a mycoplasma infection. I've never actually seen it with adenovirus, but it's been reported. These two, they do tend to be younger patients, and you'll get this episode that presents almost like a URI with then fever, or they just don't feel real well, and then you get this skin eruption of this target lesion. Then you end up seeing the skin and mucous membranes affected. And they get this really purulent conjunctivitis and episcleritis. They get horrible blepharitis, and you'll see the symblepharon form, and you end up just trying to keep the eye as healthy as possible until the process runs its course. Oftentimes trying to lyse the symblepharon or using symblepharon rings, or now we use a lot of the self-retaining amniotic membranes to place, trying our best to keep a fornix and keep the eye healthy while the eye weathers the storm. So massive amounts of lubrication. You have to watch for superinfection because you can get epithelial breakdown. The AMTs and the name brand, the Procara, which is the self-retaining amniotic membrane, can be very, very helpful as they act as both anti-inflammatories and like a symblepharon ring. Steroids may play a role in reducing the inflammation, and we do often try and lyse the symblepharon if we can. The later sequela, which we often see, is severe ocular surface disease. They've got no goblet cells left, trichiasis, limbal stem cell deficiency, and you'll end up with loss of the fornices. So challenging patients. And I've seen the inflammatory condition continue long after the Stevens-Johnson or TEN is officially said, it's done. Surgical correction can be attempted, but they are quite challenging as we have loss of stem cells very often in these patients, and we still don't have a great way of replacing stem cells, even with the limbal stem cell transplant. Not impossible, but not fantastic. And here's a couple photos of mine of a patient after her episode of Stevens-Johnson syndrome. In this case, it was due to the medication Bactrim. And you can see the scarring in the blood vessels, superficial in the cornea, the moderate to severe ocular surface disease. And if you look closely enough, you'll even be able to pick up the mild changes in the limbal stem cells. So that is a relatively quick run through of immune-mediated disease. I'm going to end the talk here. Feel free, if you like, to either email me at Ayres, Bayres, at wilseye.org, or just grab me in clinic if you have any additional questions about any of the images or what I've discussed in this talk. I may have misspoken. Sometimes what I think I'm saying isn't what I'm actually saying. So if something didn't make any sense, please come get me and I'll try and explain it. And I'll see you guys soon. And hopefully everybody's safe. All right, guys. Thanks for listening. Have a great day.